Okay, so good evening everyone. I hope the audio is clear. If there's any issue, just write in the comment section. So, good evening everyone. Myself, Dr. Rijal Agarwal. I'm the orthodontic faculty at AIIMS. So, today we are once again back our daily MDS 360 degree 1 hour power sessions at live at 8 p.m. on the YouTube. So, today I'm here with the topic, very important topic, both for a NEET and INI exam, development and occlusion. So, this topic is particularly more important in view of the fact of the numerical values which are present in this and theoretical concepts as well. But numerical data is really important from this topic. Okay, and it is more of a understanding kind of a topic rather than just mugging it up. Okay, like unlike in the previous topics of cephalometrics and model analysis where you just have to mug up those values, less of understanding. Here more of understanding and less of rectification, mugging up. Okay, so if anyone has any doubt in understanding, can very well write in the comment section and I'll be happy to help you out. So, development of occlusion. So, starting with it. So, there are four stages of dentation. First is the pre-dentate period, which is from the 0 to 6 months of age, when the child is born up till 6 months of age. Next, beginning after 6 months till 5 years begins the deciduous dentation period. In some MCQs, they also write it as a preschool period. Okay. Next comes the mixed dentation stage, which is from 6 to 12 years of age, which is further divided into three stages: the first transitional stage, the inter-transitional stage, and the second transitional stage. And lastly comes the period of permanent dentation. Okay, so these are the four stages of dentation divided age wise. We are going to look at the features of each of these stages in detail and study them subsequently, beginning with the pre-dentate period. Okay, pre-dentate, pre matlab pehle or before that, dentate means before teeth actually come inside the mouth of the child. Okay, so the development of dentition typically starts around 6 weeks of intrauterine life with the initiation of tooth birth. So when the child is inside the mother's womb, the dentition development starts at around 6 weeks of intrauterine life. Another first numerically important data. No, I can say the previous ones were these ages. Okay, so when the child is born, he is born with the presence of gum pads. So what are gum pads? These are basically the thickened oral mucous membrane of the gums which are segmented. Okay, so they are divided into various segments and each segment contains the tooth buds. So it's very easy to guess how many segments will be there inside per arch. So since there are 10 deciduous teeth per arch, so there will be 10 segments per arch. So 10 segments per arch, or you can say 20 in total. Okay, so to easily understand what are gum pads, okay, good evening Komal. So to easily summarize what are gum pads, basically they are the at birth alveolar process and they are long enough to accommodate all the deciduous teeth. So what are the features of these gum pads? So they are basically, the features are of that of the grooves or segments which are present. Okay, so there are three typically grooves. The first is the dental groove, transverse groove, and lastly the gingival groove. Okay, so what is a dental groove? So it divides the gum pad into labial and lingual segments. It starts at the incisive papilla, runs laterally and meets with the gingival groove in the region of the lateral sulcus. So this is the dental groove, which demarcates it into the labial and the lingual segment. Second is the transverse groove. So transverse grooves are the one which divides the gum pads into specific segments, that is 10 segments per arch, and each houses a developing tooth sac. Okay, now there is a special name of a transverse groove present between the canine and the first molar known as the lateral sulcus. And what it is orthodontic significance is that it is useful for predicting the inter-arch relationship. Okay, so lateral sulcus is a special name for the transverse groove present between the canine and the first primary molar. And lastly is the gingival groove, which demarcates the palatal and lingual mucosa from the gum pads. So this is the gingival groove. So predentate period, gum pad. What are gum pads? These are basically at birth alveolar process. What do they contain? They contain developing tooth sac. How many teeth are there? So there are 10 teeth per arch, so there will be 10 segments. What are the specific features? So there are grooves, 3 types of groove: dental groove, transverse groove, and gingival groove. Special name of transverse groove between canine and first molar is lateral sulcus. So this is a quick summary for the people who have joined late and what we have done until now. Anyone has any doubt? I think till now easy to understand, and I have summarized it as well. Moving ahead. So likewise in prosthodontics you must have studied the opening and closing action, and we have studied in our class orthodontics as well the hinge action of the condyle in the permanent teeth. Okay, likewise for the child and the predentate period there is a term known as plastic bite. Okay, so it's a specific term, nothing much to explain it, just a term given to the opening and closing action of the jaw and the gums at this stage. Okay, so how is it different from the one for the opening and closing action present in the permanent teeth is that when the teeth erupt, the hinge or the condyle dictates from the action of the teeth as well, the cusp and the fossa, the slopes present on the teeth. So there is not simple opening and closing hinge action of the condyle. If you remember from your prosto class, there is presence of slide as well. So the condyle opens and glides as well in the permanent teeth, whereas there is no such glide present in the predentate period. There is just opening and closing hinge movement of the mandibular condyle, and the term which is given to this is known as plastic bite. And at till what period? It is seen up to 5 months of age, a very important term for your MCQ exam, plastic bite. As I have repeatedly told you before as well, abhi it seems all good कि there is easy to understand plastic bite क्या है. When 19 subjects mix up and you get a complete exam, then there is jumbling up. Plastic bite term ortho में था, prosto में कहाँ था, bite नहीं आया. Okay, so start getting clarity for these terms and start now. It's high time to start giving your complete MCQ grand test as well, full course test. At least once a week full course test should be given, so as to get into that rhythm. Your mind frame should get into that rhythm of attempting 200 questions in the 3-hour period as well, so that once now you also get your clarity that एक subject पढ़ा तो उसको उड़ेल दिया. It's like that ना, students generally study one subject and give class tests of that particular subject which they have studied for the whole week. Okay, it shouldn't work like that. At least 2 subjects per week should be done. Anyhow, moving ahead. So what are the features of predentate period? This was earlier we discussed the features of the gum pads. Features of predentate period. So the tongue is between the lips. Okay, the maxillary gum pads, it's wider and overlaps the mandible. Again, as I said, there is no need to mug it up. It is because of the cephalocaudal gradient of growth. The maxilla develops further, that's why it's wider than the mandible. Simple. There is a presence of vertical gap between the upper and lower lip pads or gum pads, and there is a presence of anterior open bite. Okay, it is also known as infantile open bite, that is there is space between the upper and lower gum pads with contact only in the molar region. Okay, and there is a presence of complete overjet, and the jaws grow rapidly up to the age of 6 to 8 months of age. Okay, so what kind of MCQ you get in your exam? Okay, so there will be a long full page MCQ. A mother reports to your ortho or to your dental clinic with a child of approximately 3-4 months, whatever, with a complaint that there is gap between the teeth, gap between his mouth, or the child is unable to close his mouth. What kind of advice will you give to such patient? A option, start orthodontic. Surgery option, wait and watch. And lastly, assure the patient that it is a normal feature at this stage and it will close up simultaneously with time. That is the correct answer. Okay, it's not a theoretical paper, it's an MCQ paper where you get application based questions nowadays. Okay, moving ahead. So what it is next, moving towards the primary dentition phase, that is the preschool period. Okay, so from your pedo classes, you know what is the requirement of primary dentition. It is required for mastication, that is chewing, speech development, growth of alveolar processes, jaws, and the neurosensory maturation of the stomatognathic system, and lastly aesthetics. The most important point, that is aesthetics, responsible for the functional space maintainer or the aesthetic space maintainer in the anterior region. We are not going to discuss that. You must have discussed this in your pedo classes. Okay, so first we need to establish the contact of the primary first molars for the development of occlusion and bite, so as to provide the neuromuscular substrate for more complex mandible and tongue function. So as we know, there is a neuromuscular coordination. Teeth are attached to the bone with the help of periodontal ligament. The nerves run and relay a neural stimulation to the condyle through the brain, so that there is development of jaw and bones occur normally. So what are the features of primary dentition? So the occlusion of primary teeth is established by 2.5 to 3 years of age, another numerical value. So the teeth starts erupting from the 6 months, beginning with the incisors, but the occlusion, that is the maximum intercuspation, comes by the age of 2.5 to 3 years of age. So beginning with the features of primary dentition, there is spacing between the teeth, that is open dentition. So this spacing is also known as physiological development or generalized spacing, and is approximately 4 mm in maxillary arch and 3 mm in mandibular arch. Okay, and Baum classified this into two types. Type 1 is gap or spacing between primary teeth, and type 2 is primary teeth are in contact. Now this primary teeth in contact, if present, is known as Hollywood smile. And why this spacing is required for the eruption of permanent teeth, we'll discuss it when incisor liability and all in the upcoming slides. I hope it's clear until now. Okay, so another MCQ which you get. A mother reports to her clinic with a child of approximately 4 years or 5 years with the complaint of space between or gap between the front teeth. What will be your line of action? A. Start with orthodontic treatment. B. Wait and watch. C. Look for tongue thrusting habit or check for habits. Yeah, D. assure the patient that it is the normal feature of at this stage, and it will correct automatically with time. Okay, so this is the kind of questions which you get in your exam. No one is going to ask you list down the features of primary dentition in your exam. It's not a theoretical exam, it's a MCQ, and that too an application based exam now. Next feature or the normal feature of primary dentition is primate or simian or anthropoid space. So it is the space present between the upper lateral and the canine and the lower canine and the first molar. Okay, this I have already mentioned you. So in the upper arch, this space is used for accommodating the large anterior permanent teeth which are going to erupt, and lower it is used for early mesial shift. What is early mesial shift and late mesial shift, I am going to tell you in the upcoming slides. For now, just remember the term early mesial shift, and this lower primate or simian space is utilized for this early mesial shift. Okay, now as the primary teeth erupt, earlier in the predentate stage there was a complete overjet and anterior open bite. Now there is a increased overbite because of the vertical inclination of the anteriors. So another MCQ, a mother of reports in your clinic with a child of 2, 3, whatever age in this stage, before less than 5 years, any age they can get, with a complaint of increased overlap between the anterior teeth or anything. Lower teeth are not visible. Okay, these are the terms, typical terms which the examiners can use to confuse you. They won't write directly there is increased overbite because a patient does not know what is overbite and overjet. Okay, so you need to be aware what are the normal features and which don't require teeth in the intervention at this particular stage. Okay, now we move towards the exfoliation of primary teeth. Now there are two conditions which can occur. Either there can be early exfoliation or there can be delayed exfoliation. So where in what scenarios we call it early or late? So up to 6 months you have the etiology, you have the chart from your pedo classes. What are the timings of exfoliation, eruption? I'm not going to discuss those timings. So up to 6 plus minus 6 months, whatever age ma'am has discussed, the acceleration or delay is considered normal. Either 6 months before or 6 months after, it is considered normal. Nothing to be worried about. With more than 6 months of early exfoliation, there are certain factors which are responsible. They can be local and systemic factors. Systemic factors are generally syndromic factors or underlying any systemic disease. So what are the local factors? Either it can be iatrogenic extraction of primary teeth done by the dentist due to caries, due to injury, traumatic injury, or early exfoliation due to abnormal root resorption. So we need to look at these factors through radiographs and all that. Next, systemic factors can be hypophosphatasia, rickets, acrodynia, leukemia, juvenile periodontitis, or papillon-Lefevre syndrome. Another important MCQ related to the syndromic factors. So you need to remember these syndromes. Okay, some numerical data again. So rate of space closure per unit of time is more in maxilla as compared to mandible, and more in upper molar as compared to the lower second molars. Okay, so early exfoliation of upper molars, the space closure occurs due to mesialization of the permanent first molar, whereas early exfoliation of the lower second molar, the space loss is due to the distal movement of the teeth anterior to it, means the D can distalize. It's not due to the mesialization of the lower molar rather than distalization of the lower primary first molar. and the highest amount of space loss occurs within the first 6 months. So another few important MCQ related points. If anyone has any doubt until now, can ask me, otherwise I'll move ahead. Okay. Next, factors for delayed exfoliation. Like there is a early exfoliation, there are chances of delay in exfoliation or delay in extraction, falling of teeth as well. So local factors are congenital absence of succedaneous teeth, ankylosis of the primary tooth due to trauma of the gingiva is fibrost, and systemic factors are due to endocrine disturbances, syndromic or congenital defects such as cleidocranial dysostosis, and so on. You must have discussed these syndromes in detail in your oral pathology. I'm just putting up those which are important for your orthodontic point of view. So you have to link up these things from one subject to another. Okay, in your exam, true, there is a demarcation that 14 questions are there from each subject. Okay, but in the end, you cannot count and point out that this is question from orthodontics, this is from oral path. So you have done with 14, you cannot ask me the 15th question. Okay, all the subjects in medical dental fields are interlinked. So there is no clear-cut demarcation that this is question from ortho, this is from prosto, this is from oral pathology. Okay, so do not pay heed to that demarcation which comes in your prospectus. Okay, you should be more worried about your topics and study well. Okay, moving ahead. So early extraction of primary teeth can lead to delay in the eruption of permanent, and late extraction leads to accelerated eruption of the permanent teeth. Okay, just remember these facts. Coming towards the BOMS classification of primary teeth. So like we have Angles classification for permanent teeth, Angles molar classification. We have BOMS classification for primary teeth, which is related to the distal margin of the primary second molar. Okay, so what is flush terminal? The distal margins are flushing like this, are in vertical plane. Okay, mesial step, the distal margin of lower E is ahead that of the upper E, so there is a mesial step. And distal step, the distal margin of lower E is behind the distal margin of the upper E. So very easy to understand, but that's why it's so easy. The examiner doesn't ask you this thing. What they are going to ask you is the relation or how the permanent teeth are going to erupt, and what in the end they can get converted into. So in distal step, I'm going to rub this off. So the permanent first molar which is going to erupt behind this E. So in distal step, the permanent first molar are going to initially erupt in class 2 molar relation, and due to early mesial shift or jaw growth, they can get converted into end-on molar relation. So in your exam, you have to look at the term, read the question carefully, what the examiner is asking, because there is a lot of confusion or needless controversy created. Okay, so initially erupt into and can get converted into. You need to read that question carefully. And converted into, can get converted into, can be due to any factor, either due to shift, lower jaw growth, or early mesial shift or late mesial shift. We are going to discuss that. Right now you need to worry that it can get converted into end-on and initially erupt into class 2 molar lesion, the permanent first molar. So class 2, class 3, class 1 is for permanent first molar, whereas distal step, flush terminal, mesial step is for primary teeth. Okay, so you cannot apply Angles classification to primary dentition. First of all, there was one MCQ on that as well. So Angles classification cannot be applied to primary teeth. They can only be applied once the permanent first molar is erupted. Next is this application of Baum's classification. Likewise, in flush terminal plane, if the primary teeth are in flush terminal plane, the permanent flush molar will initially erupt into end-on molar addition, and due to late mesial, early mesial or jaw growth get converted into class 1 molar addition. Similarly, mesial step initially erupt into class 1 can get converted into class 3 molar addition. I hope I am clear with this. Baum's classification, initial eruption can convert it into, and there is no confusion on this. Because it's really important for exam, a number of times this is being asked and problems have been created. Okay, so no doubt, I'll move ahead. So another MCQ fact, that between 5 to 6 years of age, just before the shedding of the deciduous incisors, there are more teeth in the jaw than at any other time because of the presence of tooth buds as well. So from Wheeler's, if you remember, those cut sections of the jaw, human skeletal with the teeth, do they always convert into respected malocclusion? No, they do not always convert into, they can convert it. Okay, so in which cases there are certain nature's tendency. Okay, nature has always a tendency to make the occlusion class 1 molar and class 1 canine. Okay, how to make it into class 1 molar and class 1 canine? Due to early mesial, late mesial shift, jaw growth, nature will try his level best to do that. But if it doesn't occur, it remains in class 2, class 3, then it's a genetic tendency that we are going to study in the upcoming slides. Okay, moving ahead, the probability determination. So as I told you, the absence of spacing in the primary teeth will lead to potential need no space or less space for the eruption of permanent teeth and crowding. Okay, so there is a numerical data chart for a condition. So if the primary teeth, deciduous anterior, lower anterior teeth are crowded, there is 100% probability of permanent teeth being crowded. Okay, there is no crowding but no space as well with tight contacts, there is 70% chances. Spacing is less than 3 mm, 50% chances. Spacing between 3 to 6 mm, 20% chances, and spacing more than 6 mm, 0% or no crowding in the permanent teeth. So just remember this numerical data chart. Moving towards the mixed dentition stage. So it's, as I told you before as well, mixed dentition is divided into 3 stages: first transitional period, inter-transitional, and second transition. First transition is starts from the emergence of the first molars and the exchange of incisors. Inter-transitional period is a relatively stable period with no exchange of teeth occurring, and second transitional period is the period from replacement of deciduous molars and canines, occurs at the age of 10 to 12 years. So first transitional stage, there is eruption of permanent first molars, the primary incisors exfoliate and are replaced by permanent incisors, and there is early mesial shift. So as I told you that time also, to wait and understand what is early mesial shift. So the erupting permanent first molars, they push on the lower second molars mesially to close the primate space. So remember, I told you the lower primate space is utilized for the early mesial shift. Okay, so why this permanent molar push them? As I told you, the nature has a tendency to make the molar relation classroom. So this primate space, the lower molars, permanent molars 6's, push on the lower e's so that the first molars can shift in the forward direction and become classroom. Whereas in the upper arch, okay, the primate space is utilized for the erupting permanent incisors because they are very large mesiodistally in size as compared to the lower incisors. So they require more space. Okay, as compared to the lower incisors. Lower incisors can utilize the interdental spacing and erupt normally, whereas in the upper arch, more space is required for them. Okay, so the lower molars shift forward, the upper molars stay there. So automatically the flush terminal or whatever converts into classroom. Okay, I hope now it's clear what is early mesial shift, why it's done, why in the lower arch only primate space is utilized. I told you in the beginning only. Here more of understanding, less of mugging up in this topic of development of malabsorption. So this is a diagrammatic representation of early mesial shift. The lower permanent 6 is pushing to close the leeway space. Next is incisor liability. Okay, incisor is a tooth, liability is the extra amount of space which is becomes liability on the arch. So it was term given by Warren Main. So what is incisor liability? The increase in the mesiodistal dimension of the permanent incisors as compared to the one they are replacing. So a more amount of space is required. That more amount of space becomes a liability on the dental arches. How this liability is taken care of. Okay, so first the permanent mandibular incisors, when they erupt, initially they are a feature of transient crowding as they develop lingual to the deciduous incisors. Okay, so another MCQ, a mother reports to your orthodontic clinic of this much age of the child with the condition of crowding at this stage when his teeth or the lower incisors are erupting. On examination, you observe that the lower incisors permanent teeth are erupting or in stages of eruption or exfoliation. The primary teeth are in stage of exfoliation. What will you do? What will be your advice? Options are start orthodontic, start fixed braces, advisor expansion appliance, something horrible, and one option will be there, wait and watch or assure the mother. Similar kind, wait and watch or assure the mother. Okay, so this is the kind of MCQ you get. So how these incisor liability is taken care of? So there are certain numerical values. First of all, how much the incisor liability is there? So it is 7.6 mm in the upper arch and 5 mm in the lower arch. So how this space is taken care of? First, there is labial eruption of permanent incisors. So the permanent incisors are slightly proclined or erupt labially. So when they are proclined, the amount of space gained is more. So approximately 2 to 3 mm space is taken care of there. Next, as I told you, the lower incisors erupt in slight transient crowding at 8 to 9 years of age. Okay, so how this crowding is relieved? By the eruption of permanent canine. So the intercanine width increases with the eruption of permanent canine about 3 mm in each arch, so as to relieve this crowding. Okay, one more option you get is the MCQ which I mentioned, do IPR. Okay, so these are the common options, and last time or something the student was after me, sir IPR करने में harm ही क्या है, क्राउडिंग ठीक तो हो जाएगी, थोड़ी नुकसान तो नहीं. Okay, so here you are not answering based on your clinical experience, you are answering based on the correct theoretical concept. Moving ahead, So average tooth accommodation is derived from the interdental spacing. Remember the amount of spacing which I told you before. It is about 3.8 mm in the upper and 2.7 in the mandibular arch. Okay, next the primary teeth are upright. Remember vertical inclination, whereas the permanent are proclined. So it reduces when the teeth are proclined. The intra-incisal angle is reduced from 150 to 130 degree. Earlier they were upright, now they are proclined. Okay, very important two concept: early mesial shift and incisor liability. Moving towards the next stage, that is the intertransitional period. Now, as I told you before as well, there is not much exchange, no exchange of teeth in this stage. This lasts for around 2 years, and the teeth present in this stage is permanent. First molar 6 ED, the primary molars, the primary canine, and the incisors, and there is no significant changes or exchange of teeth occurring except the presence of ugly duckling stage. So the question comes, ugly duckling stage is seen at what age, at what stage? It is in the intertransitional phase. Okay, next question which you get is, the students don't read the MCQ correctly, is ugly duckling stage is corrected at what age? So first of all, what is ugly duckling stage? Okay, then only you will be able to understand seen and corrected. So what happens, students, is at this stage there is deciduous canine which are present and the permanent canines are coming. So the permanent canines, when they come, they tend to impinge on the roots of the lateral and the incisors, and they tend to flare off like this. So there is presence of midline diastema between the incisors. So it is seen as a feature of a duckling, so it looks ugly. That's why this term ugly duckling was given. So who gave this term first of all? So ugly duckling was coined by Broadbent, also known as Broadbent's phenomenon. Seen in which stage? Intertransitional. Next, it gets corrected, or automatically this diastema closes in second transitional space. So up to how much diastema? So 2 mm of diastema gets closes spontaneously after ugly duckling stage. So another very important question or MCQ which you get is, which of the following most important factor were to be considered before attempting to close a midline diastema with a removable appliance? It is the age of the patient. Is the patient in the intertransitional phase? You won't attempt to completely close the diastema. Okay, another controversy which is created is this. Now when I mentioned that up to 2 mm of diastema can be closed, now in your MCQ you supposedly get that a child of supposedly 10 years or 8 years or 9 years of age, basically in the intertransitional stage, reports to your clinic with a complaint of spacing or a tight space between the upper anteriors. On examination, you observe that the teeth which are present, the canines are in the stage of exfoliation, the primary molars are present, and the permanent molars have erupted. Okay, on examination, on measuring, you observe that the diastema is of approximately 4 mm, 5 mm, arbitrary values. It's more than 2 mm. Okay, now students say that, sir, you said that 2 mm diastema can be closed spontaneously. The diastema measurement was more than 2 mm. So we take the option that we'll start fixed orthodontic treatment, or we'll do frenectomy at this stage so as to close the diastema. No. You need to wait for the permanent or this stage to pass before attempting to close any amount of diastema. This is just a numerical data for you to remember that 2 mm diastema closes spontaneously. In no way I am telling that up more than 2 mm you will start to intervene and close the diastema. Do frenectomy, start ortho removal appliance, okay, start fixed appliance therapy, and etc. No, you won't do that. You will wait for the permanent teeth or the canines to erupt, then only think about some kind of intervention, not before that. Why? because if you attempt to close, supposedly these teeth are like flared, you upright them, the canines will get displaced from their position. So you were trying to treat one malocclusion, you created another malocclusion. Okay, so in exam sometimes they tend to confuse you with the amount of diastema. They tell you so much, 8 9 arbitrary values, and students like इतना ज़्यादा है, so हम close करना शुरू कर देते हैं. No, you will wait for the permanent canines to erupt before intervening or attempting anything. If we try to close at this stage, will condition worsen? Yes, Komal, that's what I was telling you. If at this stage you attempt, you won't worsen the diastema, you will worsen other things as well. Okay, so do frenectomy, start with removal appliance, finger spring, etc, etc. No, you will wait for the permanent canines to erupt before intervening in any way at this stage. I hope I am clear now. There is no confusion on this. Moving towards the next, that is the second transitional phase. So here, earlier no exfoliation, now we need to exfoliate and change the primary molars and canines and erupt the permanent canines and the premolars. And as I told you before, the correction of ugly duckling stage occurs at this stage. Common eruption sequence, which is very important for you to remember, it's 4 5 3 in upper arch and 3 4 5 in the lower arch. So the permanent premolars erupt first and later the canine, which in lower arch the canines erupt first and later the premolars. Okay, so as I told you, जो बाद में erupt, जो later erupting teeth are the most commonly displaced. So the most common kind of malocclusion which you will see is buccally displaced canine or lingually displaced lower 5. If any of you will pursue post-graduation in orthodontics, this will be the most common kind of malocclusion. Lingually placed lower 5 or buccally placed upper 3. It's because of this. Coming to the next concept of leeway space. So like incisor liability, in earlier case the permanent incisors were larger in size, so it became a liability. Now the permanent premolars and canines are smaller in size as compared to the primary molars and canine, so here it becomes a space known as leeway space. So the difference in the combined mesiodistal width of CDE and 3 4 5, it's more in the mandibular arch than the maxillary arch. Why this space is required? As I told you, nature has a tendency to convert any kind of flush terminal or end on relation into class 1. So अगर first stage में early mesial shift से नहीं हो पाया, so late mesial shift, so this exchange of teeth, this space helps. So जो space बचती है, the late mesial shift occurs of the molars to move into this space, lower में ज़्यादा है, so that any flush terminal tendency becomes class. Okay, so another numerical data. So most of the leeway space is contributed by the primary second molar, lower primary second molar mostly. So because of the significant difference in size, the E's are very large as compared to the 5 which is erupting. Okay, so therefore it is also sometimes known as E space, term given by Bishar. So कहीं पर एग्जाम में अगर E space करके क्वेश्चन आ जाए, don't get confused. Leeway space is also known as E space. So it is 0.9 mm per quadrant in upper arch, 1.8 mm in total. एक MCQ में कहीं न्यूमेरिकल डेटा गलत दे रखा है, so cannot help it, 4 ऑप्शंस है, मार्क करना है तो नियर बाय वैल्यू पे मार्क कर देना है, सिंपल एज दैट. It is 1.7 mm per quadrant in lower arch, 3.4 mm in total. This is 100% correct data. No need to get confused from that MCQ. Pulse में आपके दे रखा है. Okay. Still getting confused? Just ask me. I'll help you out. Okay. So, but average mesial shift or permanent first molar on each side is usually 2.2 to 2.3 mm. ओके, व्हाट आई मीन टू से इज अगर फ्लश टर्मिनल से क्लास 1 बनाना है सो अप्रॉक्सीमेटली 2.5 mm स्पेस चाहिए फॉर ईच मोलर टू मूव फॉरवर्ड, बट देर इज ओनली 1.7 mm space. So rest space is contributed by the growth of the mandible. Remember cephalocaudal gradient of growth. Mandible grows late. So mandible आगे जाएगा, अपने साथ अपने दांतों को भी लेके आगे जाएगा. Okay, so the difference in the sagittal growth, the mandible exceeds the maxilla by 1.79 plus minus 3.45 mm. Okay, so the mesial shift is as follows. Just to summarize, early mesial shift is due to the primate space and late shift is due to the leeway space. And I've summarized the self-correcting anomalies. इनमें से कोई भी anomaly at this age patient reports, you have to tick the option do nothing या wait and watch या जो भी आंसर में दिया, assure the patient. Okay, these are 3 kind of options which you get: assure the patient, wait and watch, do nothing. So this MCQ, supervision of child's occlusion is most critical at what age? So it is at 7 to 10 years of age, because maximum exfoliation, eruption changes are occurring at this stage. So you need to supervise the occlusion. Next comes a few terms before starting the permanent dentition, that is the safety valve mechanism. Safety valve mechanism, if you understand it from physics or your plumbing solution things, so there is a valve present to prevent the leakage of water. You close down that valve so that leakage doesn't occur. Okay, so what kind of safety valve or leaking valve is required in the growth of the jaws is the intercanine width, which serves as a safety valve. So before, just don't read it, I'll make you understand is that as I told you, the cephalocaudal gradient of growth, the mandible grows later, the maxillary growth is established first. So imagine a situation, maxillary growth khatam ho gayi, mandible continues to grow. So what will happen? If this continues to happen, the mandible will overshoot the maxilla and go forward. So for every individual in the world, there will be a broad or huge mandible as compared to the maxilla, but that does not occur. There is not every individual present with a negative overjet. Okay, so how is it prevented? Again, I am telling you how nature works. Nature tries his level best to prevent this from happening, preventing any kind of malocclusion to occur. So what happens is, as the mandible grows, the maxillary bone growth is finished, but the maxillary dental or the intercanine width growth still occurs. So the maxillary intercanine width increases so as to accommodate the increasing or developing mandible. So the maxillary intercanine width is established later as compared to the mandibular intercanine width, so as to accommodate the increasing lower jaw. Okay, so at what stage it is done? So maxillary intercanine width completes at 18 years, mandible at 10. In girls it is at 12 and in boys it is 9. I hope I am clear with the safety valve. So what does safety valve says? That the maxillary intercanine width serves as a safety valve to accommodate the growing lower jaw. The maxillary intercanine width adjusts at the mandibular dentition is brought forward. And now why the mandibular dentition is brought forward? So as to first of all convert any flush terminal or class 2 tendency into class 1. And at the same time, the maxillary intercanine width wide SD changes so as to prevent the development of any cross. I hope this is clear. Next, a very easy concept to understand, that is cone funnel mechanism. If anyone has any doubt, very important concept, please write. I'll be able to help you out. So cone funnel mechanism. So it is a mechanism to provide guidance eruption for the second molar, that is the 7. So the buccal cusp of the upper 7, that is acts as a cone, falls into the fossa of the lower 7, that is the funnel. So cone falls into the funnel. It's known as a cone funnel mechanism. So cone is called the buccal cusp of the upper 7 and funnel the central fossa of the lower 7. Next is the H-centroid relationship. So it was given by Houston and Telly. So first of all, centroid कहाँ है, H क्या है? So centroid is located in the center of the long axis of the upper incisor root, and edge is the incisor edge of the lower incisor. So normally the edge is ahead of the centroid by 1 mm. See, in normal condition the edge is ahead of the centroid by 1 mm. Okay, so in certain conditions if the edge is behind the centroid, okay, so this is more related to the overbite indicator. So when during orthodontic treatment, if you are reducing the bite or your bite opening, it is said that it is more stable, that if the edge is typically, or in the finishing stage, if we leave the edge ahead of the centroid. Okay. Next, certain age related changes in the dental arches, very important numerical data. So for the what is arch length, what is arch circumference? First of all, arch length is measured from the mesial margin of the lower 6. Okay, you draw a line bisecting the mesial margin of the lower 6 and you draw a perpendicular to it which intersects between the lower central incisor. So this is known as arch. This line is known as arch length. The length measured is the arch length. And arch circumference is when you place a brass wire from the mesial margin of the lower 6 from one side to the other side. This is arch circumference. So an arch width is measured when you keep a divider from the central fossa of lower 6 to the central fossa of the other side. So in the lower arch, the intercanine arch width increases by 3 mm and in males and 2.5 mm in females. The intermolar width increases by 2 mm in both sexes, and it is 1 mm according to Moyers. The arch length decreases by 1 mm and the circumference decreases by this much. These are all very important numerical data. Next, in upper arch, the time remaining is very less. I need to discuss permanent dentition as well, क्योंकि वहाँ थोड़ा समझने वाला concept है. So just go through them. The overjet and overbite pattern. Okay, so just understand this graph. The amount of available space. Okay, this graph is directly picked up from textbook of Profit. What it is depicting is, first of all, green is for mandible and this purple line is for maxilla. Okay, so at certain periods of time, the amount of space present becomes negative between 6 to 8 years of age, which I mentioned that when the primary permanent incisors erupt, they erupt at a stage of transient grounding. So in your exam, they can give you this graph and eliminate or hide this thing and ask you what age is there or why is it negative stage and all that. whereas in the upper arch it approaches to 0 and thereafter it increases once the permanent canine erupts. Okay, so this is telling you about the available space in the incisor segment, how it decreases when the permanent incisor erupts and increases when the canine erupts. Okay, I hope these graphs are clear. They are very very important for your exam. कुछ भी value छुपा के hide करके they can ask. Now moving ahead towards the stage of eruption of permanent teeth, which can be divided into 3 stages: the pre-emergent eruption, the post-emergent eruption, and the post-eruptive phase. So the pre-emergent eruption is during the formation of the crown of the teeth. It shows a very slow labial drift of the tooth follicle within the bone, and there is actually no eruption which occurs. So there are 2 processes which are important. First is the resorption of the overlying bone and the root of the primary teeth, and next a propulsive mechanism or the pushing mechanism to move the teeth in that resorbed space. So where does this signal for bone resorption comes from? It comes from the completion of the permanent crown, not from the primary roots. Please note, the signal or the mechanism is released from the crowns of the permanent teeth. Therefore, the resorption of the overlying bone is the rate limiting factor and not the root formation, because कहीं जगह MCQs में they ask you and you student take root formation, not root formation, the resorption, because resorption होगा तभी tooth अपने आप ऊपर move करेगा, root अपने आप नीचे बनती जाएगी. Therefore, again I am repeating, active root formation of the permanent teeth is not necessary for the eruption path or for the movement of tooth along with it. Another MCQ, that PTHR, parathyroid hormone related 1 gene mutation, is responsible for primary failure of eruption and not mechanical obstruction. Okay, so therefore this concept of dilaceration is bending away of the roots. So due to no resorption of, so there were experiments which were conducted in which they observed that overlying bone was not resorbed. They released certain factor, but the tooth continued to form. The tooth bud completed its root. Okay, so this bending of the root or dilaceration occurs because of the absence of overlying bone resorption. So the pre-emerging propulsive mechanism is provided by the collagen maturation, the localized variation in blood pressure and flow, and the forces which are derived from the contraction of fibroblast or alteration in the extracellular ground substance of ETL. Next comes the post-emergent eruption. It is the stage of rapid eruption of when the tooth first penetrates the gingiva until it reaches the occlusion level, and occurs between 8 p.m. to 1 a.m. Mostly the eruption occurs between 8 p.m. to 1 a.m. Scientific study, after tooth reaches in occlusion, the rate of eruption is controlled by the forces which are opposing the eruption, not those promoting it. So once the occlusion or intercuspation is established, as we all know, the teeth continues to erupt. Attenuated teeth continues to erupt so as to maintain intercuspation. How these forces are coming from? These forces come from the surrounding neuromuscular tissue, that is through chewing, soft tissue pressure from the lips, cheeks and tongue. Okay, normally the tooth erupts when approximately 3/4 of the root is completed. A options में 2/3 भी देते हैं कई जगह and students get confused. No, it's 3/4. Okay, it takes 2 to 3 years for the root of the to be completed when the tooth has erupted into the occlusion. Okay, another certain important data is that several reasonable normal variation in eruption sequence having clinical significance. So eruption of the second molar ahead of the premolar in the mandibular arch. So treatment is open space for the premolar. Normal eruption sequence in upper arches, premolars first, canine later. If they erupt at the same time, the canine is buccally displaced, which I mentioned before. And large asymmetries in the eruption of teeth between right and left side. So it says that normal variation of 6 months is fine. If it is more, you need to take radiographs to investigate. Lastly comes the post-eruptive phase. Post-eruptive phase comes when the teeth has reached intercuspation. Still, the teeth continues to move occlusally. Okay, why? So as to maintain occlusion, maximum intercuspation. So there are 3 stages in it. Juvenile occlusal equilibrium. So it's a phase of very slow eruption that parallels the rate of the growth of the jaws. Next is the circumpubertal occlusal eruptive spurt, that is around the puberty. And lastly the adult occlusal equilibrium. So it is a stage of slow eruption that occurs throughout the life. Absence of adhesion of teeth, absence of the corresponding tooth in the arch. You have seen अगर एक upper 6 missing है तो lower 6 erupts into that space. That's why we advise people not to keep missing space empty. Go for a replacement of that particular tooth. Okay, lastly the ectopic eruption sequence. So it's for upper molars followed by the upper canines, then the lower canines, upper premolars, lower premolars, and lastly the upper laterals. So it's a sequence which is there. Okay, so anyone has any doubt? This is the schedule of the upcoming sessions planned. So next time we will be starting with your discussion on MCQ based discussions. Okay, we won't be discussing topics like this. If anyone has any doubt, you can very well write in the comment section. I have repeatedly told you, you can join us on Facebook, Telegram, YouTube, WhatsApp group to post and ask your doubts, and we'll be very happy to solve all your queries and doubts related to subjects. Okay, if no one, then I'll close down the section. Please इसको revise करना, and numerical data is very important from this topic. Okay, so I'll close the session. Thank you for your time.